We're trying to gather all of you to be that caring community, so every person who's giving birth feels seen, heard, and taken care of.
After finding out all this information and doing so much studying, I found out that Emma was as good as this when she walked into the hospital.
I'm here to hold myself accountable and to hold those responsible. It's $12 billion to end our nation's maternal mortality crisis.
My name is Dr. Nina Ahmad, and I am a City Council member at large in Philadelphia and the chair of the Public Health and Human Services Committee for City Council. And I'm deeply invested in making sure that we reduce maternal mortality to zero if we can, and reduce maternal morbidity. This event today was with a distinguished panel coming from different parts of maternal care space to inform us after viewing a movie, a documentary about how we can make change for the better. The movie was the journey of two young men who lost their partners at childbirth. And we saw what their issues were, what they faced, and what was left, what was the aftershock that happened after those deaths. So it was a very moving documentary. It touched people very deeply, but more importantly, we wanted to turn that into action, and that's what I wanted to do with this panel and this conversation with our community, so that we can pass good, effective legislation to help reduce maternal mortality.
Thank you everyone for watching. This was really moving and tough screening, right? I've seen this 3 times now, and each time I find something new that I kind of missed the first time. And I'm very grateful to the families who allowed their pain and grief to be portrayed, so we can make something positive out of this. And that's why we are here, to have a panel discussion with some folks who have much more knowledge than I do about these issues, so I can be informed as I and my team write legislation to address how we can end this issue of maternal mortality. As you know, it is about building a community, whether it's in the maternal care system itself when the person is giving birth, or it's just a larger community. And that's what we're doing here as your legislator, as all of you community members. We're trying to gather all of you to be that caring community, so every person who's giving birth feels seen, heard, and taken care of in that process. So I would like to invite up our panelists. If you would please come up. In your program, very small print, because we wanted to fit it so much, are the bios of our panelists. I'll start with introducing our panelists. We will go from the very far end. Dr. Nina Ahmad, she's our own medical officer of reproductive health for the Department of Public Health for the City of Philadelphia. Welcome. Thank you so much for being here. Dr. Mehta has been engaged in this work for a long time, and she has been advocating for a lot of change. She's the reason why we have a maternal mortality review committee, the first in any county in Pennsylvania. So thank you for that. Then we have Joel Austin. It's so good to see him. I've known him for a long time. He's been doing this work. He's the founder and CEO of Daddy University. He serves as a strong force in propelling men and responsible parenting to the forefront our family and community agenda. You know, one of the fundamental things that we can do outside of the actual medical system is educate our patients, educate our community as to what they should expect and what they should be ready for. Those are things we can do as non-medical and non-caregiving people in this space. And then we have Dr. Shawn Ross. She is the Executive Director and Health Equity for Health Equity at Independence Blue Cross. She's a licensed registered nurse and a nationally certified family nurse practitioner with a doctorate in nursing. And so we needed, the reason why we have insurance company here, even though she comes from the foundation side, is for them to know what are we doing and what changes we need. Because part of this whole system, as you heard that Harvard doctor say, is about how things are paid for, right? So it's very important that we talk to people who are doing the paying. And next we have Dr. Sidhis Srinivas. Hold on, let me find her. Yeah, there we go. Dr. Sidhis Srinivas. She's an obstetrician, gynecologist, and maternal fetal specialist at the Hospital of the University of Pennsylvania. And her focus is to understand the etiology of racial ethnic disparities in maternal and neonatal outcomes. I have to tell you, she was at our hearing, she testified, and we've had many conversations with her, and she's given us such valuable pointers as to where to focus and what we can do as a city and as a legislative body. So I'm very grateful and thank you for all your staying engaged with us. I know you have a lot to do. But, and then of course we have Salima McNeil, whom I have known for a long time, who has been in this struggle and making sure the people's voices are heard. She's the founder and executive director of Oshun Family Center, and she's actually putting a wellness center together. She's raising funds and doing similar to what you saw in the film, and so support her and her work. And finally, we'll introduce the moderator, Joya Ahmed. I will take personal point of privilege. This is my daughter, and she came all the way from New York for this at 6 o'clock this morning, and she's going to go back at 4 o'clock, right? Because she's a medical student. She's a fourth-year medical student, and the reason why I wanted someone who's not a doctor yet, who has not entered the space yet, but is studying and can be that force of change. You know, it was mentioned in the film, so it's very important to have a voice like hers here. And she's someone who is right now going to be applying for residency to obstetrics and gynecology all over the country, and hopefully she'll get a good match. Her research is centered on health equity and patient health literacy. I think that is something that I just mentioned is going to be critical, and we in the community can do that. So without further ado, Joya, the floor is yours. If that doesn't work, I'll give it.
Okay, all right. So, first as a group, I think it's probably beneficial for us all to take one collective breath. That was a heavy piece of film to watch, and I think it showed some of the worst that we can see in terms of outcomes, but it also showed some of the best of what we can see in terms of advocacy. So I'd like to start by just opening this to the whole panel to ask, from your experience and your expertise in watching this film, what resonated the most with you as something you feel is a core issue facing maternal mortality spaces here? I'll pass them. We can start with whoever has a mic. We'll take turns turning them on and off.
Thank you so much. So I've seen this film multiple times, and it really is one of these things that really, I think, draws a lot of attention to the problem. As Councilmember Ahmad had mentioned, I've been in this space for a long time, and I would say that maybe 10 years ago, you couldn't get anyone to really think about this issue. They're like, oh, well, it's only this many people a year, right? And we think about sort of the impact of these deaths on society, and so people didn't really sort of understand that or want to at that time. But I think films like this really, again, draw attention to sort of the humanity in all of us, and we can put ourselves in these spaces and see how that would impact our family if we had something like that happen. And that, I think, really sort of, I don't know, sparked something deeply about sort of how we have to actually care about this issue. And so how it's, you know, and like the history, I think that really is peppered in, and sort of the history of obstetrics. I'm an OBGYN, and, you know, it took me a long time to really, we don't learn the history of our specialty. You know, that's not something standardly that we learn in residency. So things like that, I think, really help me do a better job on my day-to-day when I'm thinking about the work that I do. But to me, this film in general, and many like it, have really, again, sort of provided this groundswell for people to start caring about the issue, and with that, then change can happen. So to me, I think that was one of the biggest things, is really, again, calling attention to the problem and getting everybody together to fix it.
Getting everybody together to fix it. First, I am a certified postpartum doula. Yes. We exist. Once becoming a doula, I started an initiative called Doulas for Dads. And currently we have 10 black male postpartum doulas working in Philadelphia, New Jersey. What comes to my mind is, since I've sat around with Brother Charles Johnson, and I've sat with Brother Maynard, the segregation, and I know my words, not separation, but the segregation between paternal and maternal is too much of a void. How we go from intimate to you don't belong here is going on far too long, and the numbers show how bad it is without us together. The segregation, the fact that I was, at my first OBGYN appointment, I sat in the waiting room, and they took mom in, checked her, of course, and then brought me in afterwards. And I had said to the OBGYN, why did I have to wait? And they said, for mom's privacy. And it is funny. And I said, well, do you know how babies are made? I don't have stirrups, but I know, I've checked some things. So I now realize I wish I was in that room, because it's a very uncomfortable place to be. Certain things have to be cold for the germs. The stirrups are not comfortable, and I would have saw her how uncomfortable it is. And seeing how uncomfortable it is would have risen more compassion in me. So now she comes out like a regular routine, and I think it's just a regular routine. Even though she's feeling a little uncomfortable, she's feeling a little violated, I don't see that because I'm in the waiting room. So we just go on about our day. If it was different, if we were together, I would have seen it, I would have hugged, I would have cared, I saw what you went through, I would have been there. The information is segregated. She's taught things I don't know. Even though I'm cooking for her, no one has taught me about nutrition. So what I'm making her is high sodium, and high sodium now leads to preeclampsia. The fact that I can guarantee you, one of the reasons I became a doula is because preeclampsia, epidural, is something we never talk about in the barbershop. I learned this brand new word as a college graduate. I learned a brand new word an hour before it happened, which was this new word called cesarean. And the hour before the cesarean, I learned that word. I've been there for 9 months, and there's no way I should have been sitting around for that long. The segregation and the siloing of maternal health and black maternal health has caused us the numbers and deaths. This resonated with me because even though I'm in pain for the loss, I kept thinking, what have we done? What have we done to help? What have we done? And I asked Brother Maynard, Omari, who was there for you and the child, and he said just her mother. Out of all the hospital staff and out of all of this and all the services, we don't have a place currently right now. So we have started the 2 things, which is doulas for dads. We've also done one of the first baby shower for dads. It was amazing. I should have brought pictures. But one of the issues is teaching them about infant health, teaching them about how to care for mom, teaching them about postpartum depression, which specifically fathers go through too, and teaching them that what this looks like. Because in our community, that's it.
We're gonna do that.
So in our community, it is my thought is the segregation of information, the segregation of care that's caused us illness in our community.
Yes, thank you, absolutely.
I am the inaugural executive director of Health Equity at Independence Blue Cross. I think it's because Independence, and namely our CEO, Brent Evans, understood that there were inequities and disparities that existed in the membership that needed to close. And I am charged with figuring out what those, through data, figuring out what those inequities are and developing strategies to close them. One of the first things that we started working on was maternal health. And, we had to understand in all of our membership, what was the biggest driver to the disparities and the inequities that we were seeing. And we decided, the data decided that it was severe maternal morbidity. And when we did that, we then had to figure out, there were so many barriers. I know that people think of insurance companies, you could just pay for it. There were so many barriers that we had to overcome. Namely, one of them is just the data. The data it was illegal for Independence to ask the race, ethnicity, language on an application. And so when we talk about trying to close gaps between groups, if you can't even determine what the groups are, it's going to be incredibly difficult. And so, we had to lobby PID, which is the Pennsylvania Insurance Department, to allow us to obtain that type of data. Once we can obtain the data, then we can build from there. And so we have seen great progress in severe maternal morbidity since I started in 2021. But I think there is definitely still more work to be done. And honestly, it's not just focusing on race, it's focusing on women in general. I think women in general, when you think about how medications are developed, how surgeries are created, all of these various things, women are not included in that. And so that is the next thing that we're going to focus on, but maternal health is definitely the first and will continue to be our focus until we solve the problem.
So as Councilwoman Ahmad said, I'm Dr. Srinivas. I'm a maternal fetal medicine physician at the Hospital of the University of Pennsylvania. But I think as we all took a deep breath, that film was heavy. I think as a researcher, medical provider in the city of maternal health for a very long time, and all of my research is really in the space of developing care delivery models or studying care delivery models to reduce maternal morbidity, mortality, and inequities. And I think as a provider, and sort of, I think, reflecting on being a mother, being a daughter, right? That film hits us in so many ways, like each of us, from whatever perspective we're from. From my provider perspective, I think I have to talk a little bit about the medical aspects that came up in some of those, in the patients that died, and the role that we have as medical providers in doing a better job listening. I think as Dr. Mehta pointed out, this issue is not new. This issue has been going on for a really long time. And it's risen, it's documentaries like this, it's the media, it's a sort of swelling up of people, of communities to raise this issue to a level that it's getting all the attention that it has long deserved. I think as providers, what strikes me most, and what we try to teach a lot as we teach our trainees, is the listening, right? So my job is to listen, it's to piece together nuanced symptoms that people report. Symptoms in pregnancy are very common, and the same symptoms can mimic lots of different things, the majority of which are normal.
but there's a nuanced relationship of what's normal and what's not normal. And it's our job to listen, to hear a patient say that this is not normal for her, and to understand that take that for what it is, right? That they know their body best, and to figure out how to partner together to come up with a plan that everybody, particularly the patient, feels the most comfortable with. And I think it's that partnership of listening, understanding who knows their body, and being nuanced about that information, and coming together with I think the thing that I tell my patients the most is, that worries me the most is if they say to me, I just don't feel right, that is like the worst thing that I can say, right? I could look at everything, blood work and the vital signs, and they all look normal, and somebody says, I just don't feel right. That probably means more to me than what all those numbers say. And I think it's that sort of listening and just like shifting our thinking and partnering in a way that we, I think, are beginning to do a lot of. But we have to continue to have these conversations and continue to partner. And so to me, the movie or the documentary just sort of, I think, hit me in a lot of different ways. But as a provider, what do I do on the day-to-day, and how do I teach that on the day-to-day when I work with all of my trainees, is to sort of be a good listener and partner that listening with the medical skills that you're developing.
One thing that resonated with me from the film is the historical backing that we miss. I've done several grand rounds, talked to several residents, like people who are training to be in the field, and they don't know where these things come from. They just hear them or never hear them, and it's something that is greatly missed. Like if we don't know and or understand the historical implications that got us to where we are today, then how do we start to unweave that web? If you don't understand that my grandmother is afraid of you as a provider because that white jacket symbolizes something that hasn't been good for my people, and it does not change the way you interact with her, then that's problematic, because at base you should understand where that comes from. It's the same for Black Bergen people and their families that come through the doors. We are raised by our elders, we are raised by the generation before us. And although we like to lean into, if we know better, we'll do better, I say we try. Try to do a little better. So when we have like the resources that we need in order to be successful, it still doesn't mitigate some of these outcomes, because it is really me just walking through the door in my Black body that symbolizes something different for the providers, which is why the historical implication of backing is really important. So if you did not remember, my name is Salima McNeil, and I'm the founder and executive director of Ocean Family Center, which is a nonprofit organization here in the city that provides maternal mental health support to families that are birthing and their support system. So they're caregivers, gestational and non-gestational parents, and the entire family. One thing that I think was missing from the film is the mental health aspect of it, because where is the support? And it could be far and few in between, and maybe not even existent. I think in Oklahoma is where it was. And that for me is where I step in and step up and have been white knuckling it through this movement from day one to make sure that our people have equitable care, and especially therapy for culture.
Thank you all so much for these wonderful responses. Let's see if that works. Wonderful. I think something that I take away listening to all of you, and also from watching the film myself, is how much the context informs the situation, the context of a Black birthing person walking into a hospital with all of the history that came before that, and the context of a provider walking into a room potentially without that context. And I think that's a level of danger that we often don't talk about. As a medical student, most of my knowledge on all of these topics is self-education. The statistics on maternal mortality are there, and I will say credit where credit is due. The statistics are being discussed more than they used to be. It's getting better, but we're not talking about why. I didn't learn the name J. Marion Sims from my classes. I learned that from writing on my own, because I was raised by a mother who had a successful birth of me with a great deal of privilege so that I could look up those things myself. And that's one of the things that I think was really highlighted in this film, was the role that implicit bias plays. And every patient and every family member that came into this film talked about feeling unseen, unheard, or worse, seen incorrectly and judged incorrectly. So I'd love to hear from whoever wants to speak. It doesn't have to be everyone. about where you think implicit bias shows up in the maternal mortality space, but more importantly, what can we do? If you've seen something being done well, what is that? If you've seen something being done poorly, what is that? Let's get into that, because I think that was a core feature of this film.
I'll start. I actually do clinical research in collaboration with Temple University, and one of the levels of our research is an institutional level where we do diversity, equity, and inclusion training with the OB department, with the residents. We're currently starting with OB triage, which has about 64 attendings, and then we do nurses, we do support staff, and you know, change is hard. Change is really hard. So we are working to shift a system. Like, that is our lofty goal. We go in there, we're so energized around doing it. We have, you know, some resources, and guess what? If you don't have the buy-in, nothing moves. This is voluntary. It isn't mandatory. Our administration made sure that it wasn't mandatory. So getting people to buy in, and how you have to change and shift the verbiage, because anti-racism training feels too harsh. Because it feels like you're calling me a racist before I walk through the door, when we are just trying to educate you on racial implications that change how you see me, how you treat me, how you see a population of people. Things are moving. We have over 50% of the providers who have voluntarily signed on, and this isn't just a checkbox. It isn't you come to this training and that's it. It's a whole year of a program. There's process groups, and there's also small tidbits. So what we have had to come to realize is that our first initial ambitious goal was a big nope for them. And then we had to go back to the drawing board and really lean into relationship building. Because you should trust me enough that when I say your conduct or your verbiage is offensive, that you trust that what I'm saying to you is out of love, out of compassion, out of wanting to educate, versus me pointing the finger and giving you a tail wag. You know, we don't want to do that. And so I will say, I can't tell you if it's worked yet. Got like 2 more years, I can tell you if it's worked yet. But we do have buy-in, we do have support. With that diversity, equity, and inclusion training is really important, because it's also where you learn these things that aren't taught in school. And you get to sit with community providers that are client-facing to help really mitigate this issue. And those who are in it to win it. Residents are our favorite. Like, we get really good, buy-in from residents. But I will say, one mistake that we did was we shot high. We went all the way to the administration. We had all of this C-suite support, and it was like, oh, this is gonna be so great when we get to mid-level management. And mid-level management was like, we don't have time for that. We have so many things to do. We're time impoverished. We have another thing to add onto our list. And this little research study y'all have going on does not do anything extra for what I had to do with my clients. So we literally had to build relationships so they see the value in the program, which is called the Change Your Heart Study, and that they are willing to have us in their offices. We're in their lunchrooms. We're in the overnight room that the attendings are in. We really try to meet them where they are to get these small snippets of 15 minutes a piece to do that diversity, equity, and inclusion training.
That's wonderful. I think it was a great
Time to hear from some of our providers
as well, especially since we talk about time so much. How does it work? What does it look like, and how do we address it in the field?
Yeah, I think that the time crunch and how you fit it in and how you develop it is so critical. It's undoubtedly essential, right? And so that there's no surprise that policies have tried to leverage the policy lever of mandating it or including it in different ways. The problem is when you just mandate it, but it becomes that checkbox, because people can just say, well, we did this reporting and everybody did a bias training to check the box, but that doesn't actually change things, right? We're looking to change a system, to change behavior, for people to be open to actually acknowledging that they might be racist, right? And for people to be thinking about that and working on it and be committed to it and then be willing to change. And that takes training, and it takes work and commitment to ongoing interventions. And so at Penn, we have had some implicit bias trainings for our staff, our residents, our attendings through the city, through our perinatal quality collaborative. But in addition, we have this multidisciplinary group that has developed a lot of other sort of ongoing activities, which include lecture series, book clubs, and actually developing a reporting system where if you actually observe biased behavior, you can report it and we talk about it. So these are all ways that have created a really different culture around people being open to this dialogue. And so in addition to training, it's sort of all of these other activities that sort of embed the conversations, and everybody's at a different place, right? Some people are just more ready to have those conversations and other people need a little more time, but as more and more people develop the openness and understand the importance and then see the impact, you sort of start to move the system. So I think time is an issue, and I think when we think about policy levers around implementing, mandating bias training, I think they're great. I think we just have to think about how those are structured so that they're implemented in the ways that are most effective.
One of the biases that maternal health and black maternal health is not diverse. If you don't have a father or a husband on your board, then you are not DEI. You cannot claim equity, inclusion, and things of that nature. Because we're talking about babies. One of the biggest issues, because right now we teach, I'm an expert in the field of maternal inclusion and maternal health as a solution base to maternal health issues and black maternal health issues. The number one thing I always say is you have to separate my gender from my position. You have to separate my gender from my position because you look at me like I'm a man and you talk to me like I'm a man and you think I just want a football, but I'm somebody's father right now. When I watched this film, a woman did not pass, a mother did not pass. That was my wife. You need to respect the fact that there's 1,000 people in this hospital, and just because you're a woman doesn't mean you know my wife better than me. She comes to me in pain, and now I have to relate it to you. The bias is that I don't understand, that I won't get it, but the truth is that I do. The paternal inclusion has to be involved because I am next to her. I'm the person that needs to call you and say, for some reason there's blood in my toilet, I'm not sure why, can you help me out? I am right beside, I know the pain and I know the aches, and some of my mothers as clients don't even tell you the truth, but I can tell you the truth. I know what she ate. And I need to ask you, is cherry vanilla ice cream really a fruit salad, or is that something bad? I have these secrets. One of the issues of bias is that maternal health comes out of womanhood, and womanhood has its own privacies and sacredness. Maternal health comes in two difference. 36% of women are involved in a domestic violence situation. That number is too high. On the other hand, it does say, by my math, 64% are not. In a hospital, in an OBGYN clinic, in maternal health, every father knows, every man knows that she is going to be asked the question.
Yeah.
And the question is, once I walk out of the room, are you safe? I'm okay with the question. And we're okay with the question. The problem is for the 36% to say I'm not safe, and we have clinicians, we have an 800 number, we have social services, we have policy procedures to come in, we have a place you can stay to make sure that you are safe. For the 36%. For the 64% who say I'm in a good situation, we don't have nothing. We don't have anything. There's no book, there's no class, there's nothing you can join, there's no infant development. We don't teach you anything for 9 months. We don't care. There is a couch you can lay on that, and we separate you and say, even though there should be balloons and confetti that come out that says, I have a partner that's willing to help me out, willing to feed me, to make sure I know, you don't even invite me. And you look at me because you see manhood, but I have crossed over to fatherhood. And I'm totally different. So the bias is, if we're not on your board, you are not really about this maternal health work and this black maternal health work. If you don't see me involved, because I am from the start, I don't know if you understand about birds and bees and some Luther Vandross, but this is how it begins, and everything you know in birth work means every single thing that happened to bring the baby here safely that night is everything that's still supposed to happen. And I should know. You see me as a problem, but I'm not a problem, I'm just uneducated. There's a thing called Pitocin.
Yeah, oh God.
There's a thing called Pitocin. It's for a reason. What you forgot about is our intimacy. Because just a kiss from me on the back of her neck gives her enough cortisol and oxytocin to bring the same results as Pitocin. But you forgot about our intimacy. So I'm not sure what this is going to happen, but the bias is to separate my gender from my new position. Whoa.
I wanted the providers to talk before.
Did you have something, Dr. Maida? Okay,
Sure.
you can do so.
Okay. So I think it's important that, Malcolm Gladwell, a researcher, wrote a book called Blink.
Yeah.
And Blink says in 5 seconds, in the 5 seconds that I first meet you, I've already made a decision about you. As we decided at Independence what we were going to do for implicit bias, because we knew that it was a thing, we came with that lens, that most people aren't inherently racist, but they've been socialized that way. TV, magazines, whatever, you see something and you automatically make a decision when you see something similar walking down the street, or you walk into an office room, a clinic's room, and you see a patient. And so what we did was partner with March of Dimes to offer implicit bias training, not only to the physicians, but to all birth workers. So that's the unit secretary, that's the medical assistants, the nurses, the midwives, physicians, whoever is in that space. And because we knew that people wouldn't necessarily flock to that training because we can't mandate it as an insurer, we decided we were going to pay people to take it. And so we paid people to take it in 2023 and 2024. We offered this market dimes implicit bias training, and all of our licenses were used very, very quickly.
That's great. Oh, I have one. Yeah, please.
So in terms of implicit bias and does it work, or training and how you can implement that well, so we, about 5 years ago, provided funding to all the hospitals to have implicit bias training, and it was a mixed bag in terms of response. And I think that one of the lessons that we learned was really that you have to get buy-in and accountability from leadership. Sindhu spoke about that a little bit. And I think it just goes beyond, people can check the box, right? Everyone's like, okay, free training, I will do it. But if you don't have any kind of accountability mechanism for now you've done the training and now you're out in the wild again taking care of people, and then there's no mechanism to build in the what's the feedback of the people that you're taking care of? And then you receive feedback, and then what do you actually do with that, right? And how do you actually help enhance or, I don't want to say punish, but really hold people accountable for their behavior. And until you really build those systems in healthcare settings for both the feedback mechanism as well as the accountability from leadership, I don't necessarily know if just a training is going to be the answer. And so the training itself can be great, but I think that it also needs to be an ongoing thing, right? It's not just the one time and then you're all of a sudden, cured, right? Like someone, we just mentioned, right, that people are socialized for this when they're kids. And so you really have to have this ongoing conversation, and that really, again, needs to be from leadership to really be devoted to the issue and understand it.
I think what I'm hearing is not just
Ongoing, but also integrated. And I think one of the things that I'd love to touch on a little bit is the other factors in maternal mortality crisis in this country, and especially in this city of Philadelphia, that were not mentioned, right? This story focused on a couple of small, specific instances, but there's a much bigger problem at play. And so I'd love to hear from folks about some of the data surrounding what maternal mortality looks like here, what you've seen in your practices, what you've seen, Dr. Maida, in the data looking overall. Implicit bias is certainly a role. Lack of education and access, segregation of information from patients and their loved ones and support partners, all of those play a role. But what else is playing a role? What else are we missing here when we talk about maternal mortality?
So Selena sort of mentioned mental health as, you know, a big issue, a big hole in terms of like the way that care is sort of delivered and care is reimbursed and types of providers that are available. And so I think like that sort of integrating some mental health care specifically in all aspects of people's lives, not just when they become pregnant. I think that sort of, again, carries the weight of pregnancy. And we think that pregnancy is supposed to be a happy time, but actually it can be a very stressful time for people on their bodies. We have this like perception that moms are like superheroes, right? Like why is that, what super moms that are doing it, why is that something that exists, right? Like people shouldn't have to do that alone, right? It's so much, and our society is different. So I think like really thinking about mental health, but in terms of data, one thing that, you know, there was a recent article from the CDC, which I was so glad to be that it was published, analyzing hemorrhage deaths from across the country. And actually the highest cause of hemorrhage deaths are ruptured ectopic pregnancies in this country. And also in Philadelphia and also in the state of Pennsylvania, right? We don't actually, when we think about hemorrhage, right, in your minds, you're thinking that person bleeding out in the LDR. That is actually not the case here in Philadelphia. And so as you think about what are the solutions to the problems, and you think hemorrhage, you think LDR, we're doing, you know, our hemorrhage protocols, blah, 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 when in actually, the problem is some way earlier in the pregnancy, when people might not even know they're pregnant, people might not know their body, they might not understand like what those symptoms are, and that is what actually is the highest cause of death. So when you think about solutions to mortality, specifically around hemorrhage, the data is very powerful when we think about where we're going to place different systems of care. And another thing that sort of the film didn't touch on, but what we see specifically in Philadelphia and actually in Pennsylvania, is the highest cause of pregnancy-related mortality is drug overdoses. By like a lot, right? It's like 40-something% is drug overdoses, and then the next highest is 10% as complications of cardiovascular disease. Right, so if we're gonna build all of our effort on what's happening in the hospital, what doctors are diagnosing, what they're doing, then you're missing most of the deaths, right? When you think about perinatal substance use, you think about all the inherent bias that is in that space and other systems that are also biased, right? Child Protective Services, the legal system, all of these other systems that are impacted, and these patients are impacted specifically around that. That's where a lot of work needs to be done if we really want to see a decrease in a population level maternal mortality. And so that's something that, I know the data people are just kind of like, all right, the data, but like the data really does point you to like where we need to fix things if you really want to see a decrease in numbers.
So I think for us as a payer, quickly realize, like we know that racism is institutional, it's systemic, it is structural. And the only way to combat that, at least on the ground level, is through educated people. Educated people need to support these birthing people who are walking into these organizations without a lot of knowledge. And so the only thing that independents could do from that perspective is to support them with those support systems, and that's through doulas. Unfortunately, because doulas aren't recognized by the state, we had to find a workaround. And our workaround was partnering with the vendor Kayaba Care to offer those services. So when you talk of the way that you can support people with issues that are not necessarily what was in this film, it is giving them support. And however, I know the health department is giving, supporting them economically with cash. We are supporting them economically in that we are not asking our members to pay extra for doulas. We've absorbed that cost. But I think it's really important that as everyone is, whatever sector you're in, is figuring out how to support birthing people directly and not necessarily through, I think legislation is great, that's gonna take some time. If we think of improving the racial concordance, that's gonna take several decades. How can we support them directly now?
Just to add on to the conversation, I think there's really just a fundamental little bit of a disconnect between how things are paid for, and payment demonstrates value. And so when we pay for things, we show that we value them. And the way in which we have sort of developed and sort of are paying for maternity care doesn't really put emphasis on the things that are needed most to reduce maternal morbidity and mortality. And I think so having this panel where there is a payer on the panel, there are all community members, like there's community organizations, there's an intersection of all of the different important members of the team, and it's only together that we're gonna be able to think about how to restructure some of the ways in which we're developing our care delivery model and implementing it and paying for it. And I just will, I guess, piggyback on the doula comment, because to me that's an example of, it's an incredibly important member of the team. And there's the legislation aspect of that, which is, paying and incorporating it into the payment model. But a critical part of it is actually how do you then implement that member of the care team in a way that's going to actually help a patient's outcome, right? You can't just because you're paying for something doesn't mean it's gonna be incorporated into a way that's effective. And I think without all of our different sort of perspectives and disciplines in one room together, really talking about that and actually thinking about how to implement some of these strategies, we won't accelerate this work and at the speed that I think you're hearing the passion of the people up here wanting to do it. It's because we all represent different sectors that are incredibly important and have an incredibly important voice in terms of how we all work together, most importantly centered on the care of our patients.
I love what we're saying about voice and
something that I think we need to take a moment to talk about is the voice of patients. This was discussed kind of at post-mortem in the film. The voices of the people who were actually birthing these children and dying in the process were very minimally heard. And that's one of the problems, is that patients are not heard, they don't feel heard, or when they try to speak, they're judged. They're called difficult, they're called bossy, they're called frustrating, and that creates a cycle of disregard and negligence that is harmful to everyone involved. So I'd love to hear from folks on the panel, as you will, what can we do as community and medical providers to support patients in being able to advocate for themselves? And how can we support their support system, their partners, in being able to advocate for them? What does that look like in this space? And how can we champion that to make sure people are able to speak up when they need to?
This has to, we gotta meet people where they are. We are very much so a panel of providers, and we provide services. Some of us provide services, some of us pay for the services. But if you aren't where the community is, you don't get them the resources. So there are several programs. I am actually proud to be from Philly and what we're doing in the maternal health space, because I've been able to actually see in my lifetime the needle moving, right? Which some people do advocacy work and they're activists and they don't get to see things move, and they continue to do it. So that is what keeps me grounded. But what I also know is that we have some great programs in the city that are not at capacity. The programs aren't reaching the people that we know as providers need these services. Like, we have programs where they will get a stipend to get $1,000 a month. Like, where was that when I needed it, right? Like, the people were still thinking about it and now it's here, but still getting that program to have all of the participants. What I like to show people is that race concordance is really important. Being in the street with the people, being able to connect with them and give them the services. When I was in grad school to be a therapist, one of the things my professors will always say is you're gonna have a really tough time if you wanna focus solely on Black and brown communities. It's hard to get them to therapy, it's hard to treat them in therapy, and it's really just a heavy lift. So if your primary focus is people of color, you should think about what that'll do to your revenue. Because we are not in a lucrative service, we are service providers, social service providers. And I was like, okay, well, I have been out of grad school since 2018, and I don't think there's been a day that I haven't been booked and busy.
Right.
My people come to therapy. I have a 1% no-show rate for the clients, and we do over 1,000 sessions a year with multiple families. So I say that because it is not for lack of people wanting the services. It's the lack of understanding of how do you get to those services, where they are, and if you qualify. Because there are things that one thing off and you don't qualify for it. And so it makes us want to reevaluate things. But the programs are here. Being able to access them, I think, is a barrier. And also getting the information to the people that we know need it. Because as you elevate, you create distance and you're farther and farther away from the population of people. I came here from a community resource fair. I went there first to go meet the people. And then I came here. And so I like it to be known that, yeah, I run this organization, but you're gonna see my black face out there in the community talking to the people. Because when they put this big pop-up, they got Ocean Family Center, my face is all over it, I should be reachable. And that's what I think is definitely help in this Black maternal health space. In Philadelphia, we are solution focused. And everything that we're talking about, there's programs, there's been initiatives, these things are being done. We just have to wait for the data to show that it's effective.
At Independence, we thought it was really, really important to center the voice of our member. And so our members, and so we created what we call the Health Equity Advocacy Council. And if you are an Independence member, you are welcome to join this council and give us feedback on our strategy and our interventions in real time. It is quarterly, so this is really a plug. This is quarterly, is a quarterly meeting at Independence. We will feed you dinner. We will also pay for your time to, as you join the group, and tell us about what you think. We are not, I think it's arrogant to think that you know better than the people that you are trying to help. And so we have this advocacy council to get that feedback, and we actually incorporate the feedback and then report out on what we've done to make changes. Another thing is the Health Equity Summit that we have every October. It's October 7th, if anyone is a member and wants to join us, where we again share broadly all of the things that we have done in health equity and communicate the changes that we have made and the data supported evidence of it. And so I think it's, to Selena's point, it is very, very important to center the voice of the community in all health equity work.
I'll just echo the same thing and say at the healthcare and health system level, it's exactly the same approach, which is having community advisory board, like just bringing the community into the work and actually it's more of a partnership and honestly more community driven. We've really tried to have not create an agenda and get feedback, but really have an open the agenda to what our community that we're serving is asking for. And that's sort of in the clinical space, but also in our research as well. As I'm sort of as an example doing actually a research that's funded by the March of Dimes Health Equity Center that's at Penn on an integrated model, maternal care delivery model that's incorporating doulas. It's actually a research project that's developed in partnership with Coco Life, right? So it's a joint project. It's not my project where I'm just getting some feedback. It's a jointly developed project, and I think that is really something that has accelerated, and I think the importance of that cannot be stated enough. And it took us, I think, probably a little too long to get to this partnered point, but I think we're really in a space where I think probably across all sectors, really, really important to center that partnership.
Earlier I talked about the fact that we held the first baby shower for dads, but unfortunately it wasn't in my home city of Philadelphia. I had more eds and meds in this city than any other city in the world. This is the 5th largest city in the United States. I held that event in Mississippi, in Tupelo, Mississippi. They decided it was a good thing, but not in Philadelphia. The thing that irks is we do throw around partner and we do throw around community. I'm not sure why we don't use the F word, because by all partners aren't giving birth and having birth and giving the ability for a woman to have birth. So it is okay to use the F word as well. Fathers do exist, evidently, because I'm not going to talk to you about birds and bees. What keeps us going, and I say us as birth workers, is there's two strong words that really force me to do the work that I do, to talk to different things, to be at all the Black maternal health conferences. Is one word is a nasty word. It's called preventable. Preventable, there's ways knowing that if I knew more, my daughter or my new son could be alive. If I knew more, my wife would come home. And that is a very hard pill. So when I do go out and speak, unfortunately, I tell all my doulas and birth workers and doctors, and if you have to go to a funeral, you should know everybody at that funeral. If you end up having to go, which means you should not be introduced to the dad for the first time, you should not be introduced to mom for the first time, or grandma for the first time, bring them all in. Change the name of some of these things and just call it the family event for this, the family event for that. Because grandma has to come in too. She got issues. We're gonna talk about that. She still put Hennessy on it. So preventable, the family, community is important, but the family, the father, the people, the biologicals on the maternal and paternal side is very important to know and understand what's happening and what's preventable. The second one, which is, we came up with a class called The Milk is Free. It is a breastfeeding class for my fathers and men. It is not to disregard the beauty of breast milk and breastfeeding, but it's to let them know about chest feeding and everything involved. So call it The Milk is Free, to get their attention. So you have to know your crowd and know if you want them to come in. Most times we just poster something and wonder why they're not here, because most times they're just not invited. So, the second one is supports. I get tired and sick of hearing, well, mother would have kept breastfeeding if she had more supports. And it's almost like this weird place in the room where I'm like, well, I'm supports. Either I know how to help or I don't know how to help. You say she's going to the shower to help produce milk, but if I go in the shower with her, it helps produce even more milk. So you have to know these supports and what the supports are supposed to do. Our job now is to start creating these places, these supports, these classes, this education, utilizing everybody around her, making my maternal mothers the center and involving everyone that cooks for her, everyone around, everyone that's involved, to make sure they know that they are supporting and that they are helping to prevent. Because a mother is allowed to snack, and we tell all of our dads, she will snack on what's most closest to her. So if you give celery that's close and grapes that's close, that's what she'll snack on. But if you put the Doritos and Oreos there, that's something else. Our main issue, and to wrap up, is that in the medical field, the best OBGYN, the best gynecologists are the ones that work off of information that we provide. They have to be provided information. And if mom is not giving it all up, you should have to connect with me as well to say what she needed. When's the last time she walked? When's the last time she did this? So it's our job to help provide and play matchmaker, and doulas and play matchmaker with our OBGYNs to have a better relationship. So sooner or later, we need to have a medical, midwifery, doula kind of date night so that we can get together and know that my job is to give Dr. Ross as much information as possible so that she can make the best decisions as possible.
In the spirit of involving the community, having these places come together, we're actually going to open up to the audience for some questions. And we'll pass, I guess, that mic. We're going to pass that mic for folks who have questions. Did you have one thing to say first?
I had just one thing to add about the conversation around doula reimbursement. In Pennsylvania, in 2024, we are now, doulas in the state are, if they're certified perinatal doulas, have been able to enroll as Medicaid providers.
So, and allowing them to start billing for services they offer. This is a game changer. This is because, yes, we have a federal government who's paying attention to us. That came out of that omnibus bill that they talked about. And this is not a partisan space, but let me tell you who was the driver of that. Kamala Harris. She was the driver of making sure we have a national conversation. So representation matters. Who you put in spaces matters. So just remember that. I'm not telling you anything further. Just remember that. Now, the second thing is, Dr. Ross was talking about their members. Critical to understand, these are people who are insured. There's a whole population of people who don't see anybody because they don't have insurance. So those are the places where we're having real issues. So, and the fact that people can get insured, people don't even know about that. We have exchanges that we can do. So the education piece that you are so engaged in, it becomes critical about what you were saying. We have services, we have things, and we have to connect to our community for them to feel welcome and to know what is out there so they can be their own best advocate. And so I just wanted to point out those two things, that we do have doula reimbursement. However, I had a conversation with Dr. Srinivas. It's not very easy to navigate that system. So to our insurance companies and to all of those who do the reimbursement for the doulas, let's make it simple. Let's look at ending bureaucracy to make sure we get paid. And that's where legislation can matter. That's where someone like me can talk to my state counterpart and say, Medicaid is a state issue, but we can advocate for our patients here in Philadelphia to say, you guys need to fix that in order for the doulas to be effective. So I just wanted you to have that information that we do have doulas, certified doulas who can get reimbursed, and they can be providers with Medicaid reimbursement. And there, I give it back to you.
First of all, I'd like to thank you for having this forum today. I'm glad I was able to attend. Also, in watching the movie, for Tulsa, Oklahoma, has anyone received a report? Has the maternity and mortality rate decreased in Tulsa since this has been on air?
No. We don't have an answer to that, but we can get that.
All right, but also in watching the movie too, it made me think about what the gentleman was saying, that I haven't had a child in a long time, so anyway, is there still classes, especially at the health centers that the city provide, when the parents come in, they talk about nutrition and exercising? Because I know a couple of young ladies who have had children, and they don't talk about that. And I've asked her, I said, don't you go to class? Don't teach you how to change the diaper? You talk to me about breastfeeding. No, that's what I was told, so I'm just wondering if there's classes for that.
Yeah, they're there.
Yes.
Okay. So just to answer the classes, can you?
Got it. All right. We are in a place of abundance here in Philadelphia. There really are classes all over the city. A lot of the health systems still do have classes there. It is really hard to get people in those classes. They're free. A lot of times, if they're not within the hospital system, they may be low cost or even no cost. And what we're doing with the organization Ocean Family Center is that we are building an organization in a brick and mortar location that enhances the standard of prenatal care. So you can come through our doors and get your psychotherapy appointment. You can come and meet your doula, your lactation consultant, childbirth education classes, support groups, because we do see that it's very hard to go to your prenatal appointment and then pop over to another part of the city to see your lactation consultant. Maybe your doula will come out to your house. Maybe you have a home visiting program. But we are really in an abundance here in Philadelphia for services. We have to strategize a little better to figure out how to get the participants the information that they need. Because if you go to the county assistance office, I mean, maybe it's changed, but I've never really met a well-resourced income case manager at the welfare office. She's not saying like, hey, you can get $1,000 a month with the Philly Joy Bank. Here, you can go get free therapy services here. Here you go for this other thing. It just seems very like narrow, and they have a very large population of people that they serve. So I would like to strategize around it.
I agree with you on that.
First,
then her, and then you. Okay.
Thank you, panelists, for the resourceful information. I just want to say a few words about my resignation from the movie, because when my mom had told me my grandmother had died after giving birth to two twins, daughter back in China. I think at that time the midwife was not educated and she didn't know there was two afterbirth. So she only took one afterbirth after she had the twins, and she left the other one inside of her. And after like a month later, she had really bad infection and she passed away. But after that, my mother was the oldest of like 7 children, and she was the oldest, and she had to take care of all the younger siblings, and she had suffered mental health after that because of all the trauma and all, losing your mother at the age of like 7 or 8 years old, and that was really traumatic for her. So she, had tell me, to make sure, when I grow up, to make sure, I take care of myself and make sure. So when both my daughters were pregnant, I want to make sure they find the best hospital. And they had a doula and a midwife too. And I was really lucky when I had my first granddaughter that I was in the birthing room with them and saw the whole birth. That was right before the pandemic when everything shut down in the hospital. It was in February of 2020, and I was able to be there and, guide her through, and she had a healthy baby girl. So I'm very blessed.
That again, really exemplify how much a maternal death impacts society and generations, right? Like your story from your grandmother, that's like the essence of like why this problem is so important. And like as a society, we think like, oh, like I'm gonna use someone, you're gonna solve it in like 1 minute, when we know that these are generational problems and the impacts of these deaths are generational. And like a story like that, like, thank you so much for sharing that. That I think again exemplifies why this is such an important societal issue, not just for our generation, but for generations to come. And so thank you for sharing that.
Yeah, it's so important to have, maternal health.
Okay, you want to respond to her?
No, I just wanted to say real quick that sister is absolutely.
Hold on 1 second. Yeah.
She's absolutely right.
Yeah, just up there.
She's absolutely right that there is a lot of supports for maternal, but not paternal. There's also not a lot of supports for couples. We don't specifically go after the couple or the families a lot of times in these classes. So for maternal, there is. For paternal, no. There is one class in Einstein in the city of Philadelphia that helps new dads. And you get 6 weeks and that's it.
My issue is my grandfather had 3 wives back in China, like 80 years ago. So after my grandmother passed away, he had another wife, and then he had like 2 other wives after. So all the other wives had their own children, took care of their children, but not the one that passed away.
Yeah.
So all the 7 children were left by themselves, and nobody really cared for them or took care of them. And that was
We'll go to that. Take the mic. Yeah.
Hi, I'm Nina.
Yeah.
Nadine. And my name is Nadine Blackwell, and everyone on the panel except for Sister Sleem, I have not worked at her institution, but I've been a public health nurse. I work with the Fatherhood Initiative. I worked at Independence Blue Cross, which I call the plantation. Just so you know where my biases are. I worked at the University of Pennsylvania, which I call that they will put you in a study, you don't know you're in that institution. So I just want you to know that. And as a registered nurse, I've been a school teacher, and I'm a low vision therapist. So I have met patients, teenage pregnancies, persons who are visually impaired who are pregnant, patients who go to the health center and have been pregnant. And the thing is, we set out over the last 10 years to train every institution in the city of Philadelphia to be father sensitive, which Joel could tell you about. And like some people said, you can say, let's go to this training, we're going to do that. But is it implemented? Right now I'm 73 years old. When I was 22 and coming into the workforce, training meant training. You came into a job You went through everything that had to do with that job, your benefits, your training was done then. By the time I came out of the workforce, well, the paid workforce, because you're never out of the workforce, if you're in the black community and you have a high school education and above, people think you know everything, so they're always on your door, your phone. And what happened by the time I came out of the workforce, you get hired on Monday, you start work Tuesday, and you know, they say, well, you can just look on the computer. Well, then if you're on the computer trying to learn what you're supposed to do as an employee, a doctor, a nurse, then your productivity is down, and then you don't have a job. But what I want to say is that we have been trying for many years in the Department of Health to have evening hours, to have hours that patients say they can come.
Come on now.
Now, many of us don't have the type of jobs that say, oh, you can go, you can be off. So we have to flex, and it's hard to get the Department of Health to flex. And I am on the board at my local health center, so we fight for that, okay? Independence Blue Cross had a program called Connections, which really did deal specifically with different disease processes, even though pregnancy is a disease, but that enabled people to really get the care that they needed. And it was a fight. But I feel that if you're a professional, that's supposed to be your fight. That's where I feel. When I taught school, people say, oh, those kids. I'd be like, no, it's the parents and the administration. The kids doing what they're supposed to do. And as you said, you didn't know the history of your profession. To me, I don't understand that, because how can you call yourself a professional if you haven't found out the history of what you're getting into? Right. So therefore, we have to have the Department of Health respond to paternal education as well as maternal education through different hours of the day during the week, because that's when people are available. We have to have Independence Blue Cross recognize that, yes, you had programs in place that really did do one-on-one talking to patients about situations, because it is our responsibility as healthcare professionals to establish a safe environment through our communication. If I'm only going to talk to you on the phone for 5 minutes, you're supposed to know that I care about you, I'm interested in what you have to say, and it is safe for you to talk to me. And University of Pennsylvania, it's wonderful that you're there. Of course, they dropped the ball because they were supposed to take up where PGH left off when they got all that land from Philadelphia General Hospital. So the community around you, around the hospital, they're not trusting of it. And the people who they have had employed there, who had good communications with the people in that community, they've been fired for all kinds of things. So you do have a fight. Everyone on this panel has a fight. And I'm glad that you're interested in what's going on. And Nina, I can't believe your daughter's this old. Now I'm really old. And I worked so hard for you to get into council with Joe Nina. But, so I'm asking everyone on this panel to realize that being digital is not the way. That's why people don't have your information. I cannot believe of all the work that I do in the city of Philadelphia. I found out about this 2 days ago.
Okay.
2 days ago.
So we have to work on that.
And so you have to go back to paper, okay? In the barbershop, in the corner, in the poppy store, in the schools, okay? At the bus stop, with the block captains, with the newsy old lady on every street. You could ask anybody on any street, who knows everything going on in this block? Let her know about this. I am so serious. You know, I have approached women and said, you know about the $1,000, the whole, wait a minute, back up. What are you saying?
The joy bank.
Right, exactly. So this is what we have to do, and I want to be quiet.
All right. Listen, she made such a good point about communication. And we have to be, as I say, redundant in our communication. We have to do it many ways, not think, oh, I sent an email and that's enough. You need to call people, you need to post things, and we as a council office are learning what are those modes and who are the trusted messengers in the community, and making sure that they are in direct contact with us so we can disseminate this information. But what this panel really brought up some really good points about who are we talking about. You know, when you talk about the 40% who have substance disorder, right? But there's a 60% who don't. So they're also impacted. So we need to look at the whole breadth of the population who are impacted by this issue, and talking about including fathers and including other caregivers who are partners. We need to be in the barbershops. We need to be in those spaces where people go, right? And as was said, meet people where they are. So, you have a question? Yes. You be loud.
Yeah.
No.
Sorry.
Oh, sorry. There was one before. Sorry.
We'll take this as our 1 and 2, and that'll be the last couple of questions.
I actually didn't have a question. I had a comment. Prior to everything starting, I had made up my mind that I wanted to comment to Joya before she even spoke, because she was a medical student, to tell her that if I could give her any advice, but please have a voice once she gets into that hospital room. But speaking to you, or listening to you today, I don't need to say anything. I don't need to say, I've been a nurse for 40 years. I want to put my glasses back. And one of the things that I remember was in the 90s, in terms of me watching disparity and differences and not feeling like I had a voice. I mean, I was a nurse for about 8 or 9 years at that point. I watched, and it still burns on me, and I haven't been in the hospital for a while, I watched women have accelerations. And they were white women, and they immediately, they had about 2 of them, they went to the C-section. It was almost stacked. And I watched young, unmarried black girls have D-cells, as we call them. Heads up the fluid. Turn on the left side. Turn back on the right side. Put on all fours. Whatever. Sometimes 2 hours of D-cells. That difference in care. That difference. The residents at night, and I didn't feel like then I had a voice. I am certainly not that person today. And I have been an instructor, and I've taught differently. But I still think about that. I still think about the night that I was told to keep this young girl who had been there first back in the recovery room, so this white woman had a private room.
Yeah.
These are the things that I watched and saw. So I was going to say to you, but like I said, I don't think I have to, but you remind me of a number of the residents that I used to coddle a little bit and say, hey, yeah, come do this, do that. So good luck to you. I know your mom hopes you match it for Pennsylvania. So that's all I wanted to say.
We had a question in the back, and we had a question in the front.
Okay, we'll go to him.
I can wait.
You can wait? Okay. This young man is give it to her. You.
So this movie resonated with me because I'm a survivor. I shouldn't be here. I'm supposed to be 6 feet under. The doctor stood at the door as the urine ran out of my body. He had cut my bladder during the C-section. I had given him all the documents he needed to have to show that I had already had a C-section, that I had scar tissue, and I had a problem with my first C-section. That's why I had it, and this is the reason why I almost died on that table. But to your point, my son's father went and got that doctor, the first doctor, and brought him from the cafeteria up to me and said, find the cure for my woman before she dies. The second time that didn't happen. It was a snowstorm. There was no advocate for me. The help I received that evening came from the custodians. I didn't realize that I was a survivor until I watched that movie. I knew I was angry. I've been angry for a long time. That near death, because what happened was by my bladder being nicked, it burst. And I was being infected with urine. I looked like the Stay Puft marshmallow. My mother walked in that snowstorm, because I had called everyone and told everyone I was dying and that I loved them. I was not taken seriously by anyone that day. She came through the snowstorm and she saw me. My mother does not curse. She laid out the doctors. They called a neurologist, I think that's what the title was, and he looked at this mess that was my body, and he said, "Who did this to you?" And that's when I knew that I might be saved. The fear, the insecurity, the lack of confidence that you have as a person in that situation is so overwhelming that you're paralyzed. You need to have an advocate. You need someone there. I did not know, my personality had changed so much since that situation. I did not realize how angry I was still today until I watched those two young men there talking about their grief. And the fact that he had to raise his child now. And I thought about my two sons and who would have raised them. And it really hit me. I never really thought about it until that moment, until I watched it right then and there. And I was like, oh my freaking God, this should not happen today. This was 30 years ago, and it's still happening. And it's happening partially because we have to, and I was a 34-year-old woman. I wasn't a kid. I was 34. I was already high risk. I should have been treated differently from day one, and I wasn't. And I'm not alone. I was just reading the stats. More women are having their babies later. How we communicate to these women that they are at risk when people take having a birth as natural. It's no big thing. You're just going to have a baby. That's what I took it as. I didn't see that I was going to, even though I knew I had issues, I still didn't believe it would be my issue. So I think solution-wise is, like Joel said, you have to get all the parties included in there. And my suggestion is to have survivors in your groups as well. Because what happened to me is only something I can tell you about. I can now look at a law that you put out or a procedure you put out, and I can say, here's the flaw. 12 o'clock at night, from 12 o'clock from shutdown time, when you cannot have a visitor, to the time that you can get visitors again is the most loneliest time in the world in a hospital. You are totally isolated from everyone. The nurse comes if she feels like it, and the doctor told them I was a problem. I was too high strung. Don't pay me any attention. Don't come when I ring the bell. And I heard this with my own ears, so I tell you no lie. And the saddest thing, this was not a white doctor, this was a black male. And he, I found out later, treated my fiance's sister, in which she almost died because he left the afterbirth. So this is a habitual problematic doctor that no one said anything about, because we couldn't have been only 2 cases, right? Couldn't have been. So we had to tell something. When we see something, we have to tell something. We have to educate people on bad doctors and good doctors. And we have to educate ourselves. Here's my solution, aside for making sure that we, the survivors, are on these staffs, is to make sure that we're educated. Write down, as we talk to the mothers and the fathers and the sisters and the brothers and the father and the parents and the neighbors and the friends, write down what it is you expect out of this pregnancy. You know, keep a chart on your feelings and your hurt and your pains and where they're coming from, and you know, document it. And then bring that to the doctor so they can help you have a good birth. So, and I just want to say I thank you all for your support today. I did not realize that I had this inside of me. If it wasn't for this movie, I would still have it inside of me. So I'm glad that I was here today.
Thank you so much for sharing your story with us.
What did you
We have one last question up front.
This question, and then I will say.
Thank you all. I'll be quick. I know we're at the end. My name is Jan McKay, the founder and president of Life Outside the Streets, where our mission is to treat trauma through arts, education, and information using brain health and mental health. Brain health, though. Brain health is the organ where the mental health is developed. And I want to shout out Dr. Daniel Amen, who uses SPECT imaging to look at your brain and look at blood flow and brain activity to decipher through our symptom paradigm that mental health is built off of. But I came here and I just wanted to share, I'm also the program director of Philly Unlimited, an AI tech company here in Philadelphia. We developed an app to connect all the things that we are talking about as troubling to do. That is what our app company is built to do. It's a nonprofit. The technical difficulties is our parent company, but Philly Unlimited is our nonprofit, meaning providing and connecting those items and providing that platform to be connected is free. But in the areas that we need to get outreach done, we have that platform to connect to those families. And what came to me on how we could help was when the patients come in, and especially from the patients to the staff that are taking these trainings, if patients are allowed to report through a trustworthy platform, because the thing that with Life Outside the Streets and our mission being around treating trauma, the first step to treating trauma is creating a safe space. So I shifted from the awareness and the messaging campaign to our Security for Philly campaign. Because until we make every house safe and every hospital safe and everywhere safe, nothing will work. So the reason why I'm saying that, we got to present this as a security issue. When families can't get this as a security issue, the safety of the child and the family and the future of everything is connected to this. This is a security issue, and America is real good with security. We spend the most money on everything. So we got to use the right language. We got to bring security to the medical field, and I'll close with the priority of stopping the violence at the teenage level is what got me out here on these boots on the ground. But what I learned today is this is where the violence started. The violence started with the creation of this OBGYN against our children, our family, and the nation. It started with the black slaves, but it's happening to everybody in America. So I'm glad we got the right team to fix it. Let's get to work.
All right, thank you. So I wanted to thank the panel very much, but before I do that, I want to thank Jenny now. She's the one who pulled this together. A lot of moving pieces. Our offices were shut down, they were getting fixed, but she persevered, and I thank the rest of the team who supported her. So it's really important that, I don't do this work alone. I do it because of a team that's behind me, supporting me, and putting out the work. And I want to thank each one of you. Our work is not done, and I hope I can engage you, even though we're very busy, to stay connected to how do we distill this? What is our next step? So this has been recorded, and thanks to iLevel Pix, we got this recorded, and we're going to sift through the recording to actually see what you all said and connect it to the movie and bring something out. And we actually have legislation about how we mandate some of this implicit bias training in person, not sitting at a computer, but we're working through all of that to see, because it's always work, somebody has to implement that. And Dr. Mehta is saying, oh my gosh, you're gonna make me do more work. The public health department. But we all have to work together, because all of us are going to be the community that cares for that birthing person, for making sure we have a successful birth and we have new Philadelphians who can prosper. So thank you very much for coming. Thank you all. I must thank PHMC for giving us the space, and thank you all the staff who helped us make this work. And look forward to more things, and there'll be more in the community. And I'm going to talk to Joel to see how we go into the barbershop and do some other things. So thank you all, and have a great afternoon.